So my challenge for the next 10 minutes or so is to talk about particularly the challenges of implementation of diet-based therapies, particularly with regard to clinical trials. These are my disclosures. So despite the ketogenic diet, particularly as a dietary therapy being around for almost 100 years, it was only in 2008 that we managed to publish the first randomized controlled trial in demonstrating its efficacy in the childhood epilepsies. And this was very specifically in an age group 2 to 16. And subsequently, there was a further trial published in 2013 using very similar methodology, namely randomization of a group with drug-resistant epilepsy to dietary-based therapy, or indeed no change in treatment. And this second trial was utilizing the modified Atkins diet as opposed to our studies using the classical diet and the MCT diets, and showed very similar results. It was quite clear that randomized controlled trials at that time were a rarity with regards to particularly ketogenic diets. But on the most recent Cochrane database of systematic reviews with regards to looking at ketogenic diets for drug-resistant epilepsy, there were indeed 13 randomized controlled trials reported in 17 publications. The range of clinical trials that are actually reported in this publication demonstrate perhaps the challenges that may be seen utilizing dietary-based therapies in clinical trials, and not least of the fact that not all these trials looked at the efficacy relative to a different treatment or no change in treatment. Some of these trials actually looked at ways of implementing the diet, whether it be hospitalization or not, or indeed fasting or not, at the initiation of the study. That aside, for the first time, there could be some degree of meta-analysis of 4 of the trials that utilized a similar methodology, looking at the efficacy of the ketogenic diet in the epilepsies. And there were 4 trials that used similar methodology, not least to compare the diet against no change in treatment or treatment as usual, as was classified in some of the studies, and demonstrated that actually the relative risk suggested that on the ketogenic diet, they were more likely to, up to 6 times more likely to achieve more than a 50% seizure reduction. However, review within this systematic review also illustrated the problems with regard to clinical trials looking at dietary-based therapies, not least the degree of bias. And certainly looking across the studies that were included in the publications, you can see specifically the risk of bias was seen across all the studies, not least because there was very little blinding, if any blinding, of participants or personnel, whether it with regard to intervention or whether it be with regard to outcome assessment. The yellow bars also indicate the high degree of concern about the fact it could not be determined about whether there was selective reporting, whether there was incomplete data collection, allocation concealment, or indeed the degree of randomization, which meant there was a high risk of bias in these other areas in these relative trials. So when we're looking at clinical trials for dietary-based therapies, I think what the Cochrane review has illustrated is the problems, and not least if we look at the list of concerns that we have, perhaps trying to determine what may be possible and what may be reliable. Certainly there's an issue about the intervention. How can we standardize the intervention? What comparator group do we look at? Whether that be a comparative therapy or indeed no change. What degree will that be able to be measurable or not, depending on bias? Blinding, is blinding really possible from the actual intervention, or indeed should we just lead that towards the blinding of assessment of outcomes? And then we come to the actual trial itself and the difficulties that we will see, as I will illustrate, with recruitment. How can we be sure that they are complying with the dietary therapy in a standardized way? Retention within the trials, outcome measures, and of course the whole issue about duration of follow-up, to get meaningful outcomes. If we look specifically at ketogenic diet therapies, of course, there are different ways of implementing this, whether it be classical, the modified ketogenic diet, the medium chain triglyceride diet, the classical and the medium chain triglyceride diets, of course, being the full ketogenic diet, modified ketogenic diet perceived to be slightly easier. And also, of course, we have the low GI glycemic index therapy. And certainly, there needs to be some degree of standardization with any clinical trial about the intervention and a decision about what is actually being assessed. But what about the comparator group? If we're implementing a dietary therapy that provides a structure to the intake of the individual and maybe indeed the family life. So what would be a comparator that could be seen to be non-biased? Should this just be care as usual or no change in treatment? Should it be indeed a dietary-based therapy, even if this just became a structured therapy with regard to normal intake? Some of the studies, of course, have looked at an alternative ketogenic diet, and then we're not really looking at the efficacy of the actual diet itself on the condition. What about blinding? Well, of course, this has been attempted in one classic study that was published as far back as 2009. And this is the Johns Hopkins study, where they looked at children with Lennox-Gastaut syndrome. But what is key with this is that it was an inpatient study. The children were admitted for a 2-week period. They were fasted initially and then randomized. And then they were randomized to receive, both groups received a ketogenic diet, so they had the same diet, but in one group they received a glucose drink and another a saccharin drink. The group with the glucose drink thought to break the ketosis and therefore not to be on a full ketogenic diet. There was a crossover on the 6th day with fast. There would be an EEG at baseline and then subsequently after each arm. And then after the fast, they were switched to the other group, again, not knowing which group they were in, both groups having ketogenic diet, one with a saccharin drink, one with the glucose drink. Notably, there was a median change between the arms in seizures per day that didn't reach quite statistical significance. And certainly no statistical difference was seen in the EEG events. But notably, even in the seizure events were initially monitored after a fast, and one could argue maybe that had led to some improvement. And also, the ketogenic diet group that had received the glucose drink never lost ketosis. This was a very difficult study to perform, not least because the duration of time required to recruit 20 patients was a 5-year period, 1997 to 2002. It was a 2-week inpatient stay for those patients. And as I've already mentioned, the issue with regard to the methodology was gaining the ultimate result. Recruitment was therefore a problem with that study, but also seen with other studies. This study is a particular study close to my heart, not a problem, a study close to my heart in that it is still ongoing. A study that we are performing in the UK, a randomized study, looking at the effect of ketogenic diet on epilepsies in infants under the age of 2 years. And for this, it's ketogenic diet versus the next standard anti-epileptic drug. And my chart here starts at January 2018, and the study itself started in 2014. You can see there's a very slow climb in numbers per month in recruitment into the study, considering that now we have 14 sites across the UK who are recruiting. Of course, the past few months, there's been no recruitment in view of the pandemic. It was temporarily paused because of the pandemic. Now, not least the issues with performing a clinical trial in this age group, not least infants, where there is a perceived need to change treatment very quickly, the difficulties in a baseline period. But what has also been emphasised is the relative late introduction of the idea of the study, or indeed the ketogenic diet. A dietary therapy is perceived as a natural therapy, perhaps perceived after a number of anti-epileptic drugs as a better option. And when the study is only introduced when a child has failed 4 or 5 drugs, if not more, and there really is a desire to go on the ketogenic diet next, there is a reluctance indeed for there to be randomization. And this is one of the key issues as to why it's been very difficult to recruit to this study. But also at the other end of the age spectrum, there's this study that was recently published from Norway that was attempting to do a randomized controlled trial of the modified Atkins diet against treatment as usual in a group of adults. Notably, they, after 6 years, decided to close to recruitment because of the very slow recruitment rate. Notably, you can see the 277 assessed for eligibility, 129 did not meet the inclusion criteria, and 73 declined to participate because of what would be involved in following the dietary therapy. So these studies are not easy to recruit to. The ketogenic diet, not necessarily, but one end of the spectrum thought of to be the option they want because of late introduction of the study itself. At the other end of the spectrum, perhaps perceived to be difficult to undertake, and therefore and lack of desire to participate. But aside, in this adult study, once they had agreed to participate, there was still a degree of dropout before the assessment time and with regard to primary outcome, in view of the fact that 9 of the 37 patients randomly assigned to the diet group did not receive the diet, whether they changed their mind, decided to change medication, diagnosis changed, or indeed was seizure-free. And there's also the outcomes. What should we be measuring? Certainly, of course, there's the issue about whether we're measuring objective or subjective outcomes. And of course, objective measures of outcome are far more useful in the longer term. But we also have to bear in mind any fluctuation of the condition that we are actually assessing, and indeed over what duration of follow-up should we look in order to determine a true change in that baseline condition. And there's also, and I've talked about the use of the ketogenic diet in the epilepsies, but actually there's the issue about utilizing it in other conditions. And one criticism of studies where they've been utilizing it in autism is the fact that if you change the diet administration, you lead to more structure in the life of the individual, and that indeed itself may have more effect, or indeed lesser effect, than actually the content of the diet itself. And with regard to follow-up, this is just one other issue, is the fact there's always been an attempt to look at economic analysis as to what the benefits of being on the ketogenic diet. And of course, this study, the Lambrecht study, where they looked at randomization to ketogenic diet in a group of individuals with epilepsy versus treatment as usual, the primary outcome was at 4 months. And indeed, they did attempt to look at economic analysis and really demonstrated little difference between the two arms. But at 4 months follow-up, are we really going to see a big difference in that we would not have weaned any anti-epileptic drugs, and therefore the whole cost analysis probably would be in favour of treatment as usual, as opposed to the implementation of a further diet. So in summary, there's no doubt that clinical trials and dietary therapies, and I particularly utilised ketogenic diet in the epilepsy as an example, is particularly challenging. The usual premises of requirements for a standard randomized controlled trial for the assessment of a therapy cannot really be considered, in view of the fact that blinding to the treatment is not really possible and indeed not practicable. And a pragmatic trial design does have to be considered. Can we standardize the design, particularly looking at how we advise about dietary implementation? That needs to be standard or indeed consistent across perhaps more than one study. The decision on a comparator group, how do we decide on that? What is really treatment as usual? Is it no change in medical treatment? Is it changing treatment as would be indicated? Is it comparing it to an alternative dietary therapy, which indeed would give much more in the way of comparator circumstances? And the view with regard to outcomes, we still rely on reporting of seizure outcomes in ketogenic diet for epilepsy therapy. But what about other outcomes, and how can we make them quantifiable? And certainly, perhaps we should move towards blinding of outcome assessment, so that the individual assessing outcome, and whatever the outcome, needs to be blinded to the therapy that has actually been given. Although again, that's quite difficult if we're relying on reporting from carers who may actually be implementing the therapy and are not blinded in the first place. Thank you.